So just a bit conscious of time, I won't keep you guys too long, so I'll try and sift through it as fast as I can. Selena, thank you for the introduction. Firstly, good afternoon, everybody. I want to start by thanking everyone for the opportunity to present today. It's a true privilege to be considered a winner for the PRF essay competition this year. Today, I'll be sharing my piece on how digital twins and AI might actually help address ongoing challenges in chronic pain care. Further accentuating Samuel's idea of the personalized medicine approach, perhaps redefining it for the foreseeable future as well, and looking at how data-driven tools could support more predictive and equitable pain care within the NHS. Next slide, please. So, outlining some of the objectives of my talk, I'll start briefly by outlining the scale of chronic pain as a problem within the UK, why I believe current NHS pain pathways often struggle, and then using that to signpost the introduction of digital twins and AI as a proposed solution before moving into concrete clinical use cases. Finally, I'll address equity, ethical limitations, and also concerns as well as to what the future looks like with this tender integration and what realistic NHS implementation might also look like as well. Next slide, please. So just starting to lay the foundations, what is chronic pain? According to the IASP and WHO, we know that chronic pain is an unpleasant sensory and emotional experience that persists beyond 3 months and is recurring. Importantly, it's shaped by the interaction of biological, various psychological and social factors that actually signpost me to the idea of the biopsychosocial model. Why I've put this definition here particularly is, as we all know, chronic pain can't effectively just be managed through pharmacology alone, is a problem that I often see, and it should be treated holistically and three-dimensionally, being a multifaceted condition. Next slide, please. Within the UK alone, chronic pain affects around 30 to 50% of UK adults. As of now, this is roughly surmounting to 28 million people nationwide, and its prevalence is projected to rise significantly and exponentially by 2040. It drives over 5.6 million GP consultations each year and leads to major reductions in quality adjusted life years. Despite this, management remains heavily pharmacological, with opioids prescribed to around 13% of primary care patients, despite limited long-term benefits. So these are our pain-relieving drugs. So this is our codeine, these are dihydrocodeines, our tramadols. We're also seeing trends in increasing usage of more harsher drugs, harsher opioids, such as morphine and things of that nature. As a result, access to multidisciplinary pain services is often delayed beyond the 12-week goal that is outlined by the NHS. This is further exacerbating the chronicity of pain, compromising mental health outcomes and health inequalities nationwide as well. Next slide, please. So we have touched on this already from our other two presentations, but just laying the foundations from a neurobiological perspective as to what chronic pain is. Chronic pain is defined chiefly by two main mechanisms, so central sensitization and maladaptive plasticity. The idea here is that there is repeated or prolonged pain, which reduces neuronal activation thresholds within the central nervous system, allowing for more accentuated pain responses. So we see in our schematic here on the right, we see a typical brain of a patient that has been exposed to central sensitization. We see these lowered pain neuronal activation thresholds and further illustrated pain upon presentation and symptoms. Spinal dorsal and horn neurons become hyperexcitable, amplifying incoming signals and leading to hyperalgesia and allodynia as a result. These are your typical hallmark types of neuropathic pain where the nervous system misinterprets these pain signals. Microglial activation and release of these cytokines and your brain-derived neurotrophic factor allows for pain to persist even without ongoing tissue damage. We see these in conditions chiefly like phantom limb pain. So I was reading around this, and the idea is that in a patient with an amputated limb, there may be perceived pain that is caused by the central nervous system undergoing cortical reorganization, lowering these neuronal activation thresholds, rather than just experiencing symptoms from the ongoing peripheral tissue injury. It's more of a perceived pain state. Next slide, please. So before I get into the true spiel of my actual PowerPoint, I guess, I just wanted to shed some light onto the biopsychosocial complexity and appreciating it. Pain is multidimensional, it's multifaceted and should be treated as such. Biologically, nociplastic pain and cortical reorganization, also central pain processing, psychological and social factors such as catastrophizing that we see in patients, fear avoidance, depression, deprivation, and also occupational stress actively shape pain perception and disability. they are direct drivers in the hallmark symptoms that we see in chronic pain. And so treating all of this holistically and integratively is very important. NHS pain pathways currently often address these domains sequentially rather than integratively, limiting the long-term effectiveness and contributing to inequitable outcomes. This sequential approach is reinforced by early reliance on opioid prescribing, which targets symptoms in isolation rather than addressing the entire biopsychosocial model of pain, of chronic pain itself. Next slide, please. So here's why I'm useful, I guess. This is the proposed solution. I propose digital twins and artificial intelligence as a chief model in chronic pain alleviation. So just to lay the foundations, digital twins are virtual replicas of individual patients that integrate clinical, neurobiological, physiological, and psychosocial data into a single evolving model that exists alongside the physical patient and its journey through its medicinal journey, basically. Artificial intelligence here enables pattern recognition, the prediction and risk stratification across complex chronic pain profiles, allowing for the alleviating of symptoms, understanding and predicting flare-ups, for example, and together, both digital twins integrating a machine learning model like artificial intelligence would allow for simulation of pain trajectories and treatment responses before their clinical intervention. Upon my research, I actually found that the concept of digital twins has been used in early treatment strategies in cardiology and oncology, and even metabolic diseases. So from the top of my head, I remember in cardiology, there was a piece that was written predicting the risk of arrhythmia arisals and optimizing pacemakers, making sure that they're equitably administered to patients in their various cardiac needs, and also ablation strategies. And in oncology, I believe they were used in personalized radiotherapy interventions and doses, and also chemotherapy dosing as well. So very exciting. Next slide, please. So what makes a good pain model, I guess? What is actually important to integrate here? So we need a good pain model to have to learn interventions which have previously failed and have succeeded in similar patients. To provide a model, it needs to be able to capture the neurobiological signatures of pain, capturing their mechanisms that conventional assessments cannot actually quantify. And they also actively need to shape pain perception and functional disabilities, the behavioral drivers. For example, is this patient feeling chronic pain as a result of their social needs and as their social side, or is it more from a medicinal biological area that pain is being exacerbated here? Physiological stress and recovery signals also need to be used in the enabling of detection of early warning signs preceding these pain flare-ups. Next slide, please. So here are 3 use cases that I thought, particularly where digital twins and artificial intelligence, given their novelty, could actually be integrated into chronic pain. Pain flare-ups are not random events. They happen and they're very realistic, and they need to be preceded by measurable changes. The idea here is I've got a schematic here of a user interface of a cutting-edge technology called Whoop that I'm actually wearing on my wrist now. It's a little fitness band. Some of you may have used and had some experience with it. Things like these are very, very important by preceding measurable changes in sleep quality, autonomic stress markers, activity patterns, and symptom variability. These novel technologies can be used and harnessed in digital twin technology to predict flare-ups by using machine learning models. They can detect these patterns days before clinical deterioration and be used to supplement and not replace clinical judgment. So this enables for early targeted intervention, such as your pacing. It could predict the variabilities and the integration of cognitive behavioral therapy inputs for patients and physiotherapy adjustments, depending on what the variables and metrics may say in these user interfaces, medication reviews, rather than just simply having reactive one-time judgments towards crisis management. We are able to track patients in real time as to how they are tolerating treatment, being able to make typical present day adjustments to their treatment. Next slide, please. Our second use case here is the most important. What I think digital twins can be used for particularly is treatment simulation. Patient data is used to build a digital twin, which can then be used to test different treatment strategies virtually. So on our left, we have our traditional treatment intervention here, traditional trial and error prescribing, whereby a patient would come for a consultation, there would be critical liaison with the multidisciplinary team, treatments would be managed, and it's almost a trial and error basis where, due to chronic pain being so multifaceted pertaining to the biopsychosocial model, we don't know whether opioids are the exact thing that the patient would need to alleviate all symptoms, cognitive behavioral therapy, physiotherapy. Rather, we can have a digital twin simulation that we can use to simulate management and treatments alongside the patient in real time, collecting data to be used on future patients. That directly addresses the trial and error nature of current chronic pain prescribing, allowing for personalized medicine. Next slide, please. Finally, the third use case would be the post-surgical pain prevention strategy. So upon research, I actually found that around 20 to 30% of surgical patients develop chronic post-surgical pain, which is a major and often preventable source of long-term disability. Digital twins and artificial intelligence pertaining to machine learning models could be used to integrate preoperative risk factors, such as establishing baseline pain markers, psychological vulnerabilities, and prior opioid exposure, and physiological stress markers to almost predict the chances of arisal of post-surgical pain, the nature of that type of pain, given on prior performance of other patients going through the same procedures, of patient demographics and socioeconomic backgrounds. So this almost empowers the multidisciplinary team, allowing them for early detection to make tailored perioperative pain strategies and intervening before pain actually becomes chronic. Next slide, please. So just touching on that a little bit more, the MDT really does benefit from this, potentially does benefit from this novel technology. At system level, this shifts current NHS care from reactive to predictive. MDT involvement can occur earlier, referrals can be fairer and needs-based if we have information on and predictions based on how pain patients may react to certain exposures of treatment and management. Their opioid exposure as a result can be reduced, and specialist resources can be targeted more effectively and distributed more symmetrically, mitigating risks, but also having an everyone wins type model where the NHS would benefit economically, time intensively, reduce waiting times, and ultimately this reduces the chronic pain burden across the system rather than just simply redistributing known management techniques and hoping for the best. Next slide, please. So this all sounds well and good. It's amazing, groundbreaking technology that is still in emerging emerging development. But these technologies clearly are not without risks. There are huge ethical risks and limitations here. There could be data bias and representativeness. These models may be very insensitive and poorly work based on sampling quota or particular research studies, and therefore the medicine lies on the principles. We know as clinicians and medical students that medicine lies on the principles of equity and personalization. We need to make sure that these machine learning models, digital twins, artificial intelligence are integrating non-bias and being representative of the entire population, which is extremely difficult. Integrating psychological and wearable data also raises important concerns around privacy, consent, and patient trust. This may be discussed in the question discussion section, but how do we ensure that there is a sense of confidentiality with using such data and harnessing it from a third-party perspective outside of healthcare? Digital twins must serve as a supplementary tool to chronic pain medicine, not replace it. Clinical judgment and digital exclusion must be considered alongside clinician and MDT care. Last slide, please. So here's the take-home message. To conclude, chronic pain is complex, but it's not random. There is no one size fits all or one pill fits all, if you will. And that's where I believe digital twins and artificial intelligence comes in here. It's very exciting and could offer a way to move towards predictive, personalized, and more equitable pain care if used as a supplementary tool to clinical decision-making and chronic pain management, merely not being a technological cure, but a shift in mindset from reactive symptom suppression to anticipatory mechanism-informed care. For pain medicine within the NHS, this represents not just a clinical advancement, but potentially a moral one as well, allowing for chronic pain patients to have better outcomes and management. Thank you for listening.
So, thank you all three of our speakers for some really excellent talks. And I think there's a really nice common theme across all of them.